Continuing on with our discussion about home health, let's look at, about roles of the nursing, let's look at home health. Home health care looks at the 3 levels of prevention, and home health nursing focuses on empowering patients and their loved ones to getting to the highest possible level of function and health. And here we have a statement by a nurse that just talks about when you go into a patient's home to do a home visit or to provide home care, you need to remember that you're not in control of this environment. This is their home, this is where they live, and you are a guest. You are not coming in to rearrange the universe. And that can be a little unsettling for some nurses. And so we need to work with patients where they are. And there are things you can do if the home is unsafe or if there's other problems. And generally that's not the case. You can make some recommendations to how things should be moved around or changed. But unless the patient is in imminent danger, there's not a whole lot that you can do as far as coming in and telling patients how to do things. So you want to use your persuasive skills and help patients understand that they need to do this or that so that they can improve their care. So we have different practice models for home care. It can be a population-focused home care. In other words, you're going in and making this visit because of some population issue. It could be a child that had a high level of lead when they had blood testing, and so you're going in to do an assessment about lead in the home. It could be a patient who has had TB and you're making the close contact assessments of patients, people that live with them or people that have encountered them. It could be someone who had visited a restaurant and developed hepatitis, and now they're trying to contact all of the different patients, the different people that went into the restaurant that day. We have transitional care where a patient has been in a hospital for a long illness or an involved illness, or they've been in rehab and now they're coming home, and so we're helping to transition them from total care to care at home and managing this illness on an ongoing basis. We have home-based primary care where we have care that we may have a nurse practitioner or a nurse practitioner and a nurse come out and do standard primary care. And this is because it's too difficult for the patient to come into the office, and patients are more compliant with care when we have somebody coming out versus them having to pay for an ambulance to go in and get seen, or for a patient that in other words, it's a huge and extraordinary effort for them to go in, and so instead they'll send someone out. Home health is your skilled nursing care where you're going out to do a dressing change or help administer insulin or do an IV medication dose, that sort of thing. You're doing some type of skilled care. And then hospice and palliative care may also be given in the home, and we'll talk about that in our next video. So with population-focused home care, we're looking at evidence-based data and data-driven approach. So we've done our research, we know what's going on, we know why there's a threat to the population, and we need to go out and see this person. And so this may be very focused education and specific things that we have to do based on regulation and so forth. This can also be patients with a psychiatric illness. We can also maybe going and looking at all the different diabetic patients who live at home, that kind of thing. Transitional care, this is where we're coordinating care from the place that the patient has been to where they're going. And we may have some just basic general interventions, and we may have some high intensity interventions. We have patients in home care who are on ventilators, they may be on tube feedings, they may have central line care. It's really extraordinary what people have at home and what we can do at home. And so as the home care nurse may go and visit the patient in the hospital before they come home, and we may participate in discharge planning, or we may first find out about the patient after they've been home. And so then we'll do some follow-up visits, and then they may go in and see their primary care person, and they may also be seeing certain specialists, and then we coordinate with that provider office and find out if there are any changes in orders to the patient's care. And then after this patient is discharged from the agency, we're still going to follow up with them and see how they're doing. And so home-based primary care, as I said before, is an alternative to going into a primary care clinic and getting care. So they can have health problems that makes it very difficult, or it may be an extreme anxiety issue, and so they cannot come in because of the anxiety involved. And places that do this are places like the VA. There are physicians under Medicaid. When I worked for Medicaid, we had patients that had nurse practitioners or physicians that would come out and do visits. In home health, you're going to provide care for the patient at home. If it's a Medicare certified agency, then they have to be homebound. That means it's a very difficult effort for the patient to leave the home, and they don't leave the home except to go to health care appointments. And so this is usually circulatory disease like venous thrombosis or venous ulcers, stasis ulcers, and so forth. It can be patients recovering from an MI, patients who have wound care and so forth that they can't manage. They may have had surgery and they're having drains. They may need IV care. And so they have some type of skilled nursing need. And this is just a schematic of different home care agencies. The official ones that can be run by the government, like the TB program. You can have a voluntary private home care agency where you have private duty nurses. That someone will say, you know, I don't want to pay for somebody to go and check on my mom every month. And so this is a private duty care where somebody decided, I want care. Then you can have a combination of any of these, and some agencies will offer all of these services. You can have a hospital-based agency where you are following up on patients that went home from your hospital. You see this a lot with mother-baby care. Someone will go out and see how things are going with a new mom. You can have a proprietary agency, and this is the most common type of agency, an agency that's privately owned. And they decide what kind of patients they want to see based on what reimbursement they want. And so with home care, you want to provide a goal. And if this is a Medicare or a Medicaid patient or other insurance, you're required to have certain care goals, and you evaluate those goals to help you know if you're meeting your criteria for care. And we have the OASIS assessment. This is generally the assessment tool that every home care agency uses. You go out and complete this form. It's around 20-25 pages. It takes about an hour and a half to do, and it's very comprehensive, looking at the patient, their medication, their treatments, all the physicians or providers that are involved in their care, wounds and so forth, and other problems. And so all of this is done, and then it's transmitted to CMS or their insurance company, and then they will read that and determine if the patient is accepted for care or not. And then they give you certain outcomes that you need to follow. And so you develop that plan of care based on those outcomes. And so the home care nurse may go out on Monday and help administer insulin. And then they would come out on Tuesday and watch the patient administer insulin, and then they may also teach them about hypoglycemia and so forth. So each visit is tied to one of the outcomes. And we're going to end this, and then we will talk about palliative care.